Sean bienvenidos. El día de hoy estamos muy contentos porque tenemos una sesión extraordinaria, que de verdad va a ser extraordinaria. Tenemos un ponente invitado que la compañía Braco nos ha hecho llegar y, bueno, viene con temas muy interesantes, innovadores para nuestra práctica diaria. De verdad, sean todos bienvenidos a todos los que están aquí presentes. Muchas gracias por el esfuerzo, a pesar de la lluvia, del tráfico, de todo. Gracias por estar aquí. Y a todos los que nos ven vía internet, también muchas gracias por conectarse. Les damos la más cordial bienvenida. Soy la doctora Araceli Cabanillas y presidenta de la Sociedad Mexicana de Radiología. Y le voy a ceder la palabra al doctor Alejandro Vega para que nos pueda hacer la presentación de nuestro ponente. Muchas gracias.
Muy bien, buenas noches a todos. Vamos a dar una breve reseña curricular del doctor Dirk André Clevert. El doctor Clevert es el jefe de la sección del Centro de Ultrasonido Interdisciplinario del Hospital Universitario de Großhadern de Múnich, que forma parte de uno de los complejos médicos más grandes de Alemania. Desde el 2004, el profesor Clevert dirige el Centro de Ultrasonido Interdisciplinario en la clínica de la Universidad de Múnich, en Múnich, Alemania, y realiza todos los ultrasonidos intervencionistas en el mismo, incluido el ultrasonido mejorado con contraste, y en un año el centro realiza aproximadamente 20,000 exámenes de ultrasonido en 7 sitios. El profesor Clevert ha publicado más de 115 artículos en revistas médicas nacionales e internacionales y es miembro de los consejos asesores de varias revistas científicas. Ha presentado más de 370 conferencias y presentaciones científicas en congresos, cursos nacionales e internacionales, y sus intereses de investigación abarcan los campos de la ecografía con contraste y la ecografía intervencionista y vascular. Como ven, hoy tenemos el gusto de tener al doctor Clevert para que nos hable un poco más sobre el ecorrealzador y sus funciones y sus usos, que es algo que cada vez está creciendo y estamos teniendo más acceso aquí en nuestro país. Entonces le damos la bienvenida al doctor Clevert y muchas gracias por su presencia. Doctor Clevert.
So good evening. It's a great pleasure to be here in Mexico, one of my favorite places. And I'm very keen to see how much doctors come in their free time in the evening to listen to this lecture. I have also a couple of training cases for you. So if you use your mobile phone, you can scan the QR code, and then you have got over 700 training cases free of charge for every modality. So just scan it with your mobile phone, and then you get these cases. So my first talk will be about the value in vascular pathologies and the role of diagnosis of focal liver lesion. We know that approximately 5% of the whole population has got a liver lesion. Unfortunately, at the day of cancer of diagnosis, around about 25 to 50% of patients has already liver mets. In order to offer the best treatment, we have to know, is it a benign liver lesion or is it a cancer? Therefore, we have to have a special contrast setting. So if you look at this old system from the year 65, even if it is an equipment from Germany, it will have no success if you inject contrast. Why? Because you need a special software. This software gives you the option that you can use the contrast option. Don't try it without this software, because the most time you will fail. You see, the size of a single bubble is very small. The size is like a red blood cell. The first generation of bubbles was filled with air. Since more than 20 years, Sonovu is on the market and it's filled with gas. All bubble has got a shell. So it's either a palmitin shell, albumin shell, or lipid shell. And the major difference in comparison to CT or MRI contrast agent is that we are speaking about a pure blood pool contrast agent. This means the contrast agent will stay in the vessel, will not leave the vessel, except if you have got an active bleeding, then it will leave the vessel. How it's working? we see this single bubble there. A probe send a wave and it decompress and compress the bubble. And then the bubble work as a backscatter. This means you get more signal. More signal means you get more than 30 dB. And if you have experience with ultrasound, all you have, 30 dB is a huge amount of signal you received. So if you have got the proper software on your system, you see the oscillation of a single bubble. If you will try it without this software, this bubble will immediately burst and you have no benefit from the contrast agent. All patients have to give an informed consent that they accept that you are allowed to inject contrast. The good news is these contrast agents have no influence on kidney or thyroid function. This means we don't need any lab. For example, if you go to CT or MRI, they ask for the kidney lab. But here, you can directly start. The amount of contrast is very low, so it's just roughly about 1.6 cc followed by 10 cc of saline. When we speak about vascular lesion, we have three phases. And here you see the three phases: the arterial phase, portovenous phase, and late phase. The time mean the length of the arterial phase is 10 to 15 seconds. The length of the portovenous phase is 30 seconds to 2 minutes. And after 2 minutes, late phase starts. If you look at these three phases, you find typical characteristics for each liver lesion, which is different. In this talk, we will see a couple of benign liver lesions, but we also see a couple of malignant liver lesions. On the one hand, the benign, so we have hemangioma, FNH, adenoma, cyst, focal fatty sparing, and abscess. On the side of the malignant liver lesion, we have got liver mets, CCC, and HCC. Starting with the benign liver lesion. Remember, we have got these three phases: arterial phase, portovenous phase, late phase. So, in the arterial phase, the lesion have got a perinodular enhancement. So you see an uptake like a nodule in the peripheral. Over time, these nodules are growing, and at the end, the complete lesion is filled. So, I'll show you here. We see our typical behavior like a hemangioma. So we inject contrast, and there you see these nodules. And over time, these nodules are getting bigger and bigger. And if the hemangioma have no thrombotic changes inside, then the complete hemangioma is filled with contrast. You see, completely filled. Now, if you take your time, every examination starts with a good grayscale. So you have to optimize your grayscale. After optimize your grayscale, you go to color Doppler. And afterwards, then you start with contrast. Don't make a mistake and start with contrast at the beginning. Good chance to fail. We see there's a hypergenic lesion, subcapsular on the liver. This lesion doesn't show major vessels. In the next step, we prepare our contrast agent and inject some contrast. You see, this lesion have got a perinodular enhancement. You see this nodule there, there's a nodule there. And additional, also look at the gallbladder. There's a polyp, also nice uptake here. Even here it works. What happens in the portovenous phase and late phase? You see these nodules are growing and growing, and in the late phase you see only then there's no uptake because there's some thrombotic changes inside, but most of the lesion is completely filled. If you find this pattern, you can say with the diagnostic confidence round about 95%, this is a hemangioma. There is no need for biopsy, and there's also no need for CT or MRI, because it's clear. I mean, now you're an expert regarding hemangiomas. Did you find a liver lesion here? You can take your time, look carefully. We see part of the left liver vein, the mid liver vein. What about the right liver vein? There is a huge lesion which compresses the right liver vein. Will be your diagnosis that this is a hemangioma in grayscale or color Doppler, or could we not make a diagnosis only in grayscale or color Doppler? I think probably you could also flip a coin to make a decision, because this could be everything in grayscale or color Doppler. Now we go to contrast. You see contrast arrived in the liver, and then you see automatically there's a nodule, there's a nodule, and you see these nodules are growing and growing. So we go to the later phase, portvenous phase. There is contrast inside, here is contrast inside. You see most of this lesion have an uptake. Inside there are thrombotic changes. So this is typical for a giant hemangioma. Also, no need for biopsy. Now we are going to FNH. So there's a strong uptake in the arterial phase from the center to the peripheral. And the portovenous phase is either hypergenic, and the same in the late phase. We see our FNH here. Sometimes FNH could be very difficult to see in the grayscale, because sometimes they have the same echogeneity. So we inject contrast. You see from the center to the peripheral. Strong uptake. You see the central scar inside. And you see no washout in the follow-up. Very easy. So we see there's a lesion just adjacent to the gallbladder. This lesion shows a lot of vessels. In the next step, you see from the center to the peripheral. Again, from the center to the peripheral. Very strong uptake. Portovenous phase, no washout. And late phase also no washout. So you make the diagnosis, this is just a FNH. Not every FNH is eitherogenic. Sometimes they are hypergenic. So we see there's a lesion. This lesion has got a diameter around about 1.5 centimeter. By looking at color Doppler, we see there seems to be in the center a vessel, as we've seen it here. So we go to the contrast, and you see there's a lesion, strong uptake from the center. You see there's a feeding vessel to the peripheral. Again, you see the first bubble arrive from the center to the peripheral. Afterwards, we go to the portovenous phase, and late phase, you see no washout, no washout. Even if we burst the bubbles, you see this refill. So you can make a diagnosis, tiny FNH. Adenoma, a little bit more difficult. They have got a strong uptake in the peripheral, and they have got a filling from the peripheral to the center. Sometimes in the late phase, there's a slight washout, but only a slight, not complete. So we see our adenoma. You see the uptake in the peripheral and a filling from the peripheral to the center. There it is. And remember, not every, but a couple of adenoma have got a slight washout in the late phase. there's the lesion. This lesion has got a diameter approximately around about 3 centimeter. We also see some vessels, but we see more vessels in the peripheral in comparison to the central part. Then we inject contrast, and you see very nice the uptake from the peripheral to the center. And if we follow up, you see no washout, and even in the late phase, it's completely filled, this adenoma. We just destroy the bubbles, and you see the refill from the peripheral to the center. So small adenoma here. Liver cysts are very, very easy. Why? Because we are having a blood pool contrast agent. If it's a liver cyst, it will be liquid inside. This means no contrast uptake. You see in all 3 phases, no uptake. There's our liver cyst with a posterior enhancement. And if we inject contrast, you still see it looks similar, but no contrast inside. There we see our lesion. We see some peripheral vessels, but no vessels inside. It's not completely dark. Normally, cysts are more dark. So we start with contrast. You still see no uptake inside. Even here, no uptake inside. So you could make the diagnosis it's just a liver cyst. Again, you see, we destroy the bubbles and the refill, but no uptake inside. Abscesses are also easy. They have got a rim enhancement. In the center, they have no uptake. So we see our abscess here. They have got an uptake in the peripheral, strong rim enhancement, and no uptake inside. Now you see there's something wrong in the right liver lobe, and ask yourself, how big is this lesion? Is there only 1 lesion, 2 or 3? And will be your best diagnosis at the beginning that this patient has got an abscess? By looking at Doppler, we don't see vessels inside. But maybe Doppler is not as good to show even small vessels. So we repeat it. You see this strong rim enhancement. You see this? If you see this, you know exactly this is an abscess. And it's not only 1, it's 3 or 4. And of course, these abscesses have to be drainaged. And if you ask you, how big is this abscess? Look in the later phase, you see it much clearly. This abscess has got a diameter probably more than 12 centimeter. And of course, these patients are major ill. You have to place a drainage there very fast. If you now place a drainage in abscess, often we have got a problem that there might be a dislocation of the drainage, or the doctor asks you, how big is the abscess? Or they ask you also, does this abscess have contact to the bile duct system? So, what you can do, you use only 2 or 3 drops of contrast agent and 10 cc of saline and inject it over the drainage. You see some air inside, abscess here. It has got a diameter around about 3 centimeter. And now we inject contrast over the drainage. You see that's the complete extent of this abscess. You see also no uptake of the liver inside, only the abscess. And look at here, you see this is drainage. You see no contrast out subcapsular to the liver. This means a good position of the drainage, no contact to the bile duct system, and you could measure very easy the maximum diameter now of this abscess. So this takes 2 minutes. Normally you have to bring this to fluoroscopy and inject joded contrast, much more difficult. The next part we would like to speak about malignant liver lesion. So, according to the primary tumor, liver mets has either a very strong uptake, a moderated uptake, or less uptake. But all of the liver mets have got a clear washout. And this clear washout starts in the most time in the portovenous phase. So we see our liver mets, there it is. So we inject contrast, you see strong uptake, but also a strong washout. If you have this behavior, you know exactly this patient suffers from a liver mets. We see this patient had got lung cancer. The patient comes to the follow-up examination, and we find plenty of liver lesion. So we see there's one, here's one, there's a tiny one. We also see some vessels inside. By injecting contrast, you see this lesion show a moderated uptake. The lesion is nearly complete, filled with contrast. Then we go to the portovenous phase and late phase, and you see it show a clear washout. It's getting darker in comparison to the normal liver tissue. So you can write the report, liver mets. What about this lesion? Will be your first diagnosis that this maybe is a liver met, or should it be more like a cystic lesion? I mean, it's nearly completely dark inside. It has got this posterior enhancement. And now the question is, liver mets or liver cyst? By looking at color Doppler, we could not detect flow inside. And remember, the treatment will be completely different. Liver cyst, no treatment. Liver mets, treatment. You see this lesion show an uptake. You know exactly after 2 seconds, if you see the first bubble inside, it's not a cyst, it's liver mets. And if you go on and look later, you see the lesion starts to wash out. Now it's completely washed out. So you make the diagnosis, this is just a liver mets. CCC have got a rim enhancement in the portovenous phase, and in the late phase they have got a washout. So we see our CCC here. So rim enhancement and fast washout. We see there's a lesion with a hypogenic capsular here. This lesion is in the center of the liver. This lesion has got a diameter approximately 7 centimeters. If we inject contrast, we see this rim enhancement there, but also an uptake inside. But you also see very fast that this lesion show wash out. And if you wait a little bit longer, you see how big is this CCC here. It is at least probably 10 centimeters in the center of the liver. So huge CCC in the center of the liver. Now we are starting with HCC. HCC have got a strong uptake in the arterial phase. It has got chaotic vessel pattern. In the portovenous phase, it's isogenic, but they have got a washout in the very, very late phase. When we speak about HCC, keep in mind that 4 to 6% of all HCC also could show up in a non-cirrhotic liver. The contrast behavior will be the same as in a cirrhotic liver. So we see our HCC, we see the uptake inside, strong uptake, and you have to wait up to 3 or 4 minutes until you see the washout. Much longer like CCC and even much longer like liver mets. Now take your time. We see this patient has got a cirrhotic liver. We also see that the patient have got ascites. But did you see the HCC? Maybe here? So if we inject contrast, you see this lesion there show a strong uptake. Much stronger in comparison to this area. In the portovenous phase, no washout. We still wait, and then you see at this area, it starts to have a slight washout, and later you see it's getting a little bit darker in comparison, for example, to this part of the liver. So, just a tiny HCC. Did you find a lesion? Sometimes if you have got a big liver lesion, it's difficult to see. But in this case, you have got a lesion. There's the lesion. This lesion shows a lot of vessels inside. So you see a strong uptake, much stronger in comparison to the normal liver tissue. No washout in the portovenous phase. Then we still wait in the late phase, nothing happens. And even we see and wait longer, now we see a slight washout. And if you even wait longer, now you see washout and washout. Sometimes you have to wait up to 5 minutes to see the washout. So don't stop the examination after 2 minutes or 2.5 minutes. Sometimes, if you think about HCC, you have to wait a long time. How good is this? There's a couple of studies which compare conventional ultrasound in comparison to contrast and ultrasound. And you see, just as the results, it's much better. You could improve your diagnostic confidence by using this technique. How good is it in comparison to CT? And if you look at the results, they said there is no significant difference between contrast and ultrasound and CT. Now I would like to switch a little bit. In the morning, I was asked whether I have also images regarding liver transplantation. So we include now liver transplantation. Generally, you have 3 options, or 2 options. No, 3 options. Either you start for contrast before liver transplantation to exclude or to find liver lesion, and to make a clear diagnosis whether you have got a portovenous thrombosis or a tumor infiltration. On the other side, you can also use contrast during liver transplantation and also on the follow-up. Take your time and look at the CT and ask yourself, did you see an HCC? So, who of you see an HCC? Nobody. Okay. I will give you the ultrasound information. And I repeat the same question. Did you see an HCC? Who see an HCC? I don't see nobody. Just give me a hand sign if you see an HTC. Okay. Now we combine the strengths of CT and ultrasound in a single image. So I give you both. So you have got the CT information and the ultrasound information. And in this color box there should be an HTC with a diameter around about 2.5 centimeter. Do you believe me? No. Okay. We inject contrast. Did you see a lesion? It was there. And this makes a big difference for the patient. Now we could confirm this patient has got an HTC. So either it will be treated or patient will in the ranking for liver transplantation on a higher rank. Okay. Now we see patients with inflammatory diseases like hepatitis, they go often to our department and they received a normal ultrasound scanning without contrast. But they also additionally received often MRI. In the MRI, they describe a small, tiny HTC with a diameter about 1 centimeter. In our examination, we have not seen it, so the patient come back. We use the tool. You see there in the MRI is a tiny HTC. So in this image, there should be also a tiny HTC. Did you see it? Not clear. I help you something. Look, I mark this lesion with a blue marker, and the blue marker is transferred in the ultrasound image. And where the blue marker is, there should be a HTC. Did you trust this blue marker? I think the only solution will be contrast. Okay, remember, there is a blue marker. You see the blue marker there? Okay, so we inject contrast. What about this lesion there? There's a lesion, 1 centimeter. And we miss it in ultrasound. And look, this lesion also have a washout later. So it confirmed the diagnosis. Now 2 modalities confirm an HTC. Patient will be on the list for liver transplantation on a higher rank now, because 2 modalities have confirmed it. On the other side, before we do a liver transplantation, you have to make sure whether the patient has got a portovenous thrombus or not. So I show you the grayscale of the portal vein, and I show you the same with color Doppler. And I ask you, did you see a partial thrombus in the portal vein? For those of you who have experience, they may say, is this a thrombus there? We also see there is an incomplete fitting with color. But I think there's a good chance to miss this. Now repeat the examination. Hepatic artery, that's fine. And what about this there? It's much easier to see. There's a small thrombus in the portal vein. This patient received heparin for a couple of weeks, and then this will be gone. What about this portal vein? Something is here, and what about this? And the question is this maybe a tumor thrombus, or is it just a thrombus? So we have to prove it. We can use color Doppler, we can use this new power Doppler technique. You see there is no flow inside. So maybe it's just a thrombus. Now we inject contrast. You see very nice, there's a thrombus there. Also here's one. So if you look a bit later, you see big thrombus in the confluence and part of the portal vein. And there's the second one. You see it here. So two thrombus in the portal vein. And the thrombus have no contrast uptake inside. And you can say it's just a thrombus. It's not a tumor thrombus. Look at the portal vein. Everybody agree this is either a tumor thrombus or it's a fresh thrombus of the portal vein. Because the diameter is enlarged, it must be something fresh. By looking at color Doppler, we could not detect any flow inside. We see only the hepatic artery here. Now repeat the examination. Hepatic artery, portal vein. You see the complete portal vein is dark. This patient suffers from a fresh portal vein thrombus. You see the complete extent. Huge thrombus in the portal vein, it's complete occluded. If we compare this now with this portal vein, we see some calcification inside. This means something happened, but this was a couple months or a year ago. It's an old one. Color Doppler could not see flow. Now we inject contrast. You see a very strong hepatic artery. That's typical if there's an occlusion of the portal vein. But you see, portal vein also is completely occluded. This is an old thrombus in the portal vein. And now we are coming to the challenging cases. Remember, you have seen something similar. You see only a strong hepatic artery, and you see no flow in the portal vein. Is this a tumor infiltration? Could you make the decision only by grayscale and color Doppler? So we inject contrast, hepatic artery, and you see immediately uptake inside of the portal vein. You see a complete tumor thrombus in the portal vein. Because a tumor thrombus is alive. This means it will also have blood inside. And with the blood inside, we could detect it by contrast. What about this thrombus here? There. Is this just a thrombus as you have seen it? Or is it a tumor thrombus? Who think about tumor thrombus? Okay, and who think about normal thrombus? And who think we need contrast? You got the message. But remember, we do it step by step. So we use contrast, color Doppler. We see there's no flow. You see there's a thrombus. But even with this technique, we could not detect flow. So you see very strong uptake, and you see these noduli show an uptake there. You see this much faster, and now the portal vein is filled. So you see there's an uptake, there's an uptake. So two tumor thrombus in the portal vein. And if you wait a little bit longer, you see very nice these tumor thrombus. There's tumor thrombus, that's the portal vein. And here is the HCC which infiltrate in the portal vein. Make a big difference in thinking about liver transplantation or not. So what a complication could be? You have seen after liver transplantation, Either we have got a partial or complete occlusion of the hepatic artery, that's the most problem. Portal vein make less problems, the same like liver vein or IVC. We can also use this technique to detect hematomas or to exclude any perfusion defect. We can also use it, think about control, like an abscess as we have used this. Or sometimes you find incidental liver lesion which was not described before. And then you have to make sure, is it a benign lesion or malignant lesion? The recommendation will be baseline ultrasound grayscale, followed by color Doppler, power Doppler, and afterwards we can use contrast. Also, it's very helpful if you store images as a clip. You can go backwards and scan and see what happens from the beginning until the end. So, if you look at this image, you know exactly this patient underwent liver transplantation in the past. All information are there. You see, this is the old portal vein, this is the new portal vein, and here's the connection between the old and the new one. So if you have got a stenosis will appear in this area of the portal vein. You see, color Doppler, a nice filling, no lysing, seems to be fine. So if we inject contrast, see strong hepatic artery, nice filling of the portal vein, everything perfect. This is a normal case. So when we speak about complication, we could think about what is the major problem. The major problem is the hepatic artery. And up to 10% of all cases, there's a problem with the hepatic artery. This is the most critical case, vessel, because it's also a small vessel. So either you have got an occlusion, a stenosis, pseudoaneurysm. When you think about portal vein, either you have stenosis, thrombus, and this could also show up in the hepatic vein. This is a patient who had already the second liver, so 2 times liver transplantation. Unfortunately, the liver function getting more worse, and there was an increase in the lab. So they asked us if we should do scanning, and if we do the scanning, you see immediately these hypergenic areas here. You see they're like a triangle. If you see this, you know something is major wrong. By looking at color Doppler, we see the hepatic artery, also in power Doppler, but I only see the portal vein. I could not see the hepatic artery. So what I thought, there might be an occlusion of the complete hepatic artery. That's the reason why the patient has got the necrosis in the peripheral. So we know this vessel is a portal vein. And remember, contrast arrived in the hepatic artery earlier, like in the portal vein. So if you see contrast for the first time in the portal vein, then you know hepatic artery is occluded. So we're focusing only on this vessel. So contrast arrived, you see, there it is. Before something uptake in the peripheral, it's in the portal vein. This means this patient has got a complete occlusion of the hepatic artery. And you see these huge necrosis there. And if you compare this to CT, you see this major problem on the left side or on the right side. Unfortunately, we was not able to receive a third liver. Patient was dead 24 hours later. Really, immediately. Another case. So if you look carefully, you see this is really strange. It looks like a subcapsular hematoma. You see this band, subcapsular band here, which is very dark. By color Doppler, we could see hepatic artery and portal vein and also liver vein. You see also nice curve of the hepatic artery, and we see also here a nice flow of the portal vein. There it is. Now we inject contrast, And you see, this is a reperfusion defect. This means the organ was not perfect prepared. But you still see some vessels causing it. So in this case, it looks also very strange, but we do nothing, and the patient survived. And if you look at the CT, this looks also very, very strange. Reperfusion defect in the transplant kidney, transplant liver. This patient underwent liver transplantation. In the follow-up, the patient received an MRI. In the MRI, they describe a hemangioma. In the previous examination, there was no report of any hemangioma. That's the reason why the patient came back to our department. So if we look at this area, we see some vessels here. But this really doesn't look like a hemangioma with these big vessels in the peripheral. So we inject contrast, and then you see very nice, a huge pseudoaneurysm of the hepatic artery with thrombotic changes inside, but not a hemangioma. If we have got the pseudoaneurysm in the liver, these pseudoaneurysms have to be treated, because if there will be rupture, the patient has got major problems afterwards. A good way to treat the pseudoaneurysm is you look for the feeding vessel, there's a pseudoaneurysm, and then you use some microcoils to occlude the feeding vessel. This takes a half hour, really easy. So you see also on the grayscale, these white areas here, these are the clips inside. What about the vessel? We could not see it in the peripheral anymore. So we inject contrast, and you see a complete exclusion of the pseudoaneurysm. So good treatment. So very nice treatment, and also no major infarction of the liver. That's an interesting case. Remember, I told you, if there's a stenosis, the stenosis will be just at the connection of the anastomosis. So if we measure inside, the angle is fine. We got a velocity in the portal vein more than 300 centimeters. That's 10 times higher than a normal portal vein. So there must be a stenosis. So if we inject contrast, you see hepatic artery, there's a stenosis. And also, if you look later, there's a second one here. One stenosis is here, and the second is here. This vascular surgeon doesn't trust us, so they will send to the MRI, and you see exactly the same. One stenosis, two stenosis. Patient underwent C-plastics, so this have to be under surgery. Look at the conjunction between the donor of the liver and the IVC. This area is very, very small. By looking at color Doppler, we see a lighting here. This means there's a stenosis of the liver vein in connection to the IVC. And you see pretty good the stenosis. There's a stenosis. And of course, also this stenosis have to be treated. This is a very interesting case. It's a rare case. This patient underwent liver transplantation, but this patient had also a stent graft in the IVC before. During liver transplantation, they forget this and compress the IVC. They have to compress the IVC, otherwise the blood is too much. But you see now there's a stent graft. And then they ask us, is there any flow in the IVC? Yeah, we see a little bit flow there. By looking at contrast, we see very nice the stent graft is there. Contrast arrived. Liver seems to be fine. And now you see there's the contrast in the stent. So what you now have to do, you have to bring another stent graft inside in the middle of the stent, explant it, that there is no problem with the blood flow. So a second stent graft will place in the old stent graft to bring the stent in the normal form. You see there, it's completely compressed here. We have also some limitation. Think about reaction. Are we able to detect reaction only by grayscale, color Doppler, or contrast? No, unfortunately not. So, what are the take-home points? If you think about fresh liver transplantation, contrast has got a major advantage. It is also recommended from the EFSAM. And if you think about the multi-slice CT, we have seen even here that it has some limitation. If the contrast time is not perfect, we have also a good chance to miss, for example, HTC. And also, we can use this information of complication and look on the IVC or on operation suite directly, side by side. In the detection of liver lesion, conventional grayscale or color Doppler has limitation. In order to get rid of this limitation, we need contrast. It's the same like if we do scanning in CT. We use contrast if you think about vascular diseases or liver mets. It's the same like in ultrasound. Normally we don't use contrast, but contrast is available. And the costs are low. There is an option to split vials because we have 5 cc of contrast inside. This means you could do 3 patients with 1 single vial. In our daily work, in our department, we do round about 1,200 cases every year for contrast. And if I look at my liver lesion, round about 30% of all liver lesion I do, they have already a CT or MRI in the past. And they describe that they couldn't find the solution, they recommend contrast. With my last slide, of course, I would like to welcome you to Munich, either as a guest or online. And if you need more training cases, just use the QR code, scan it, and then you have got 700 cases. Are there any questions regarding the first talk? Or should we discuss it after the second talk together, whatever you like? After the second talk together or separately?
After second talk.
Okay, perfect. So, in the second talk, I will speak about the benefit of contrast and ultrasound by using unclear liver, by finding unclear liver lesion. We know already that 5% of the whole population has got a liver lesion. We know that at the day of cancer diagnosis, round about 25 to 50% of all patients has got liver mets. In order to offer the best treatment, it's important to know whether we speak about a benign liver lesion or whether we speak about cancer. Just to summarize, contrast agents have no influence, or ultrasound contrast agents have no influence on renal or thyroid function, but of course all patients have to give an informed consent. What options did we have if we think about liver lesion? We can use grayscale, we can use color Doppler, we can use this kind of special power Doppler microflow imaging, but we can also use contrast. And nowadays we have also the option to use super res microvascular imaging and also time of arrival in the liver lesion, that we see where does contrast arrived, where is the area of strong uptake and less uptake. I mean, you have seen now all liver lesion. So we can do it interactive. There's a lesion. This lesion has got a diameter, maybe 2 centimeters. We don't see major vessels inside. Did you have already a good diagnosis for this lesion? Or what will be your best diagnosis? Hemangioma? Maybe. Okay, we prove it. So we inject contrast. You see there's a lesion. You see these nodules there. Everything is fine. You see these nodules are growing and growing. And now we summarize everything in one single image. This means super res, contrast enhanced ultrasound, time of arrival, and motion compensation. You see normally the patient breathes, and then you see this movement. But the new software gives you the option that there will be a motion compensation. You see peri-nodular enhancement. The area which is red, this is early uptake. The area which is blue is later uptake. So you can see less uptake in the peripheral, no uptake in the center. So this confirms also the diagnosis of a hemangioma. Another lesion. There's a lesion. What will be your diagnosis? Is this also a hemangioma? It is not as clear as the first case, but maybe it's also a hemangioma. So we inject contrast. You see there's a timer. You see very nice peri-nodular enhancement. In the center it's dark. These nodules are growing over time. Then we switch to the portovenous phase. You see more and more contrast is inside. And even in the later phase, it's filled with contrast. So if you look at the pattern, just hemangioma. Even it's not so clear in the grayscale, contrast confirm it. And now if you compare with this new technique, super res MFI and time of arrival, you see very nice this nodular uptake. You see this movement that is excluded. You see the bubbles where I have got strong uptake. And you see all the information is now in one clip. So this will be the latest options which are available and also which improve your daily workflow. We make it more difficult. There's a lesion with a diameter around about 7 centimeters. By looking at the power Doppler, we see some vessels inside. Color Doppler doesn't show vessels inside. What will be your diagnosis, or what kind of lesion is it maybe? We need contrast, oh? Okay, so we can stop here. Thanks, Bracco, I have done my job. No, just kidding. You see, this lesion shows peri-nodular enhancement. So even here you see strong uptake in the peripheral. These nodules are growing, and you see in the center it's a little bit black, but most of the peripheral have got an uptake. So you also see hemangioma. If you now would like to summarize it in a one-stop shopping image, again you see this one-stop shopping image. There is the hemangioma with peri-nodular enhancement, and you see the arrival time at the same information, at the same time. Multiparametric imaging. We also use it in the MRI, but it now also finds its way in ultrasound. Who think about the hemangioma? No. Huh? No. Sure? How sure? 100%? 100%. Okay. Last chance to check it. Okay. Perinodular enhancement. Over time, you see more and more contrast arrived. Nearly complete filled. Atypical hemangioma. So if you have got a fatty liver, this lesion is darker, hypergenic, but the contrast behavior is the same. So sometimes we have also hypergenic lesion with our hemangiomas. Nobody have thought about hemangioma if you look at this lesion, but it's a hemangioma. Also here, information. You see in the beginning, perinodular enhancement, and you see over time more and more contrast arrived. Either in this high-res mode or in the time of arrival. You see? Very nice. Who think about hemangioma? Personally, when I find a liver lesion in a cirrhotic liver, my first thought is HCC, honestly. But maybe you have got another thought. Who think about HCC? Okay. Who think about hemangioma? No. Okay, we prove it. Perinodular enhancement. So we have also hemangioma in cirrhotic liver. They are rare, but they exist. And you see over time, you see more and more contrast arrived here. So also hemangioma. So you can flip a coin to make a decision, hemangioma or not. Because hemangioma could be isogenic, they could be hypergenic, they could hypergenic, they could show up in a cirrhotic liver, they could be everywhere. Okay, now I have got a really rare case. There's a lesion. It is not a hemangioma, I tell you. No hemangioma. Yeah, absolutely. But this lesion you will see only once or twice in your life. Because in the most time, either we are too early or too late. Any idea what kind of lesion did you see here? I will give you some more information. Look at for contrast. This lesion is dark. If we take a while, then we see some contrast here. There, you see this? And if we look later, you see contrast is from here. This is an active bleeding in the liver. And the rest is hematoma. As I told you, either we are too early, then you don't see this, and if it will be compressed by himself, then you're too late, next day it's gone. So active bleeding in the liver. See, very nice, there the active bleeding. Look at this lesion. Could be also everything. By looking at Clevert, we see a lot of vessels inside. So maybe, even if we look at the power Doppler, we see vessels inside. Maybe it's an FNH. From the center to the peripheral, strong uptake. Central scar. Fantastic. Even if we combine the power Doppler with contrast works, and you see even the late phase, the movement from the bubble from the center to peripheral, this is an FNH. You see the super rest time of arrival. In the center, you see the first uptake because it rests inside, peripheral, and also see now very, very tiny vessels, which is not really clearly visible in the normal conventional contrast ultrasound setting. So improves the resolution. This lesion looks similar, but this patient had got a cirrhotic liver with ascites. Diameter is also same. We have also a couple of vessels now here inside, like the FNH you have seen before. But you see very, very strong uptake, chaotic vessel pattern, different behavior. In the late phase, only a slight washout in this area. If we summarize the complete story, you see time of arrival and super res, HCC. Now, if you compare, the lesions are very similar. You see the pattern is different, the vessels are different, and the uptake is different. You see much stronger the uptake everywhere, but here you see from the center to the peripheral. What kind of lesion? The hemangioma? Yes? Maybe. By looking at Doppler, yeah, some peripheral vessels, no strong. Also, you see it confirms perinodular enhancement. You see this nodule there, it's growing and growing there. So it's a tiny hemangioma with a lot of thrombotic changes inside, but it's still a hemangioma. If we summarize the information, you see very nice in the peripheral this perinodular enhancement, and you see these thrombotic changes inside because we could not see any contrast inside. Now, last chance. Who think about hemangioma? Okay. Who think about liver mets? You got me. We see some small vessels here, but if you look at this power Doppler, a little bit more vessels in comparison to this area. That's not so typical for hemangiomas. Okay, now we inject contrast. There's our lesion. Did you see any perinodular enhancement? No. But what do you see? Later, wash out. This is a liver mets from neuroendocrine tumor. And the grayscale looks very similar or looks identically. Also here, if you summarize the information, you see the uptake inside. There it is. And if you would like to compare, look, in the grayscale we thought about hemangioma. Yeah, hemangioma, but this will not fit with hemangioma. Rare case. What kind of lesion did you see? This lesion has got a diameter around about 1 centimeter. color Doppler and power Doppler are not able to show any vascularization. Any suggestion what kind of lesion? So we inject contrast. No uptake inside. It's not alive. Even in the portovenous phase and late phase. So what will be your diagnosis? Yeah, hydrated cyst. Typical for hydrated cyst is this very bright echo inside. So you see hydrated cyst. You see this new technique, there's the lesion, it has no uptake inside, and you see very tiny vessel in the peripheral, but no uptake inside. This is also a very interesting case. Is this an atypical hemangioma? No. Oh. Color Doppler or power Doppler, I think there are some artifacts inside, but normally we don't see vessels inside. We have some bright areas in the middle. You see a very, very strong rim enhancement. Over time, no uptake inside. And if you look at the results, it's an abscess. Look here, how beautiful you can see. Strong uptake, early uptake in peripheral, strong uptake inside, but no contrast inside. Abscess, and of course, this abscess have to be drainaged. Hydrated cyst, abscess. Abscess has more uptake in the peripheral. Hydrated cysts have no uptake in the peripheral. Also, these multiparametric imaging help you to make a clear differentiation and summarize information in a single clip. I love hypergenic lesion. You know, I love to also to share with you. We make it easy. How many lesions did you see? Dos. Perfect. And did you have a name? I tell you, it is not a hemangioma. Mets. Okay. So we see atypical vessels here. It doesn't fit with normal liver tissue. It must be something else. So no fatty, focal fatty changes. It must be something else. We inject contrast. We see also that the patient has got a problem with the heart because, first of all, the contrast arrived in the liver vein. That's normal. If you've got a problem with the heart, then contrast arrived early over the liver vein or not over the hepatic artery. But you see these two lesions just come back. You see liver vein uptake. There's a lesion and there's a lesion. So it confirms that it is not a hemangioma at the beginning. And you see no washout there and there. Normally, your contrast examination will be closed here, and you have to make a report. What you will write in the report? There are two lesions. Adenoma, could be. Vascular malformation, it's kind of malformation. Look. Where does contrast arrive? You see these red dots inside? From the center, red means earlier, blue and green mean later, from the center to the peripheral. So this patient has got 2 FNH. You see, very nice. You see these red areas also here. So you can make the diagnosis 2 FNH. With contrast, with normal contrast, is much more difficult. But due to the fact that these super res MFI, we get more information and it summarizes and help you to make a proper decision. My last part of this talk, I would like also to focusing on pregnancy, because we debate today, can we use contrast also in pregnant women? There's only limited studies which show the advantage. We have published a couple of studies, but if a woman is pregnant and finds a liver lesion, what option did we have? We can bring them to CT, but this is not good for the baby, and not good for her. We can do MRI, but we should not give gadolinium. So we have only a very, very small window for making the examination. But contrast have no side effect on the baby. It will not go to the baby. It will not crossing the placenta. And it has no radiation. So in the first study, from 2005 to 2014, we have included 6 patients. After publishing this, we find very early more than 22 patients the following year. In this year, we already had more than 12 pregnant women with unclear liver lesion. We also have found unclear myomas, we have found unclear kidney lesion, we have found unclear subcutaneous tumor, which we use contrast, so we expand the rule of pregnancy. And we have never had a side effect. We was very strict and look at the lab also, and it was a very safe examination. The application is exactly the same, but normally I would recommend that both parents sign the informed consents. So this is a 25-year-old female, 23 week of pregnancy. She had got rectal bleeding. That's the reason why she received a CT. In the CT, they describe a liver lesion. You see there's a lesion. What will be your diagnosis? Maybe hemangioma? Okay. I use the fusion tool, so I combine the strength of the CT and the lesion. You see, not hemangioma, because no peritoneal enhancement. And unfortunately also washout. This means also in a young woman, liver mets could be show up. And why? Because she has got rectal cancer with liver mets. Another case. This woman had got in the past MRI. They describe a couple of FNH. This woman is in the 35th week of pregnancy, and she suffers from a lot of abdominal pain. Her house doctor tells her that's normal, baby, make pressure, that's complete. But also she would like to confirm the diagnosis of an FNH. So I use the old MRI, I use Doppler, grayscale. I thought by myself, yeah, might be FNH. Then I inject contrast. Is this the typical behavior for FNH? No. Normally FNH has got a strong uptake from the center to the peripheral. And if you see here, this lesion show wash out. So I said it's cancer. But we have to prove what kind of cancer. So I do the biopsy. There's a biopsy of the liver lesion. There I bring the needle. I do two biopsy. And unfortunately, this was mets from pancreas cancer. Very, very sad story. That's a very interesting case. Why? Early pregnancy, 8 weeks of pregnancy. This woman had got abdominal pain, so she received an MRI without contrast. In the MRI report, they describe either it's a necrotic tumor, or an abscess, or a hydatid cyst. You know, all three need different treatment. So how to handle now this? Okay. I look at grayscale, this lesion, hypogenic. Did you see vascularization inside? No. Oh? Okay. You see very strong this rim enhancement. If you see this, you know exactly the diagnosis after 2 seconds. Abscess. Remember, hydatid cysts have no rim enhancement. Necrotic tumor have no rim enhancement. So this was a mammalic abscess of the liver. Better than a necrotic tumor. We also summarized all the information in our first study, and we have found no side effects. And in every examination, it have got an advantage in the diagnostics. Important is informed consent from both parents. Before we start the examination, we look at the baby, if the baby is fine. Because you never know what happened in the baby in the past. So you have to confirm that the baby is fine and show the woman baby is fine. Then we do the examination, and after we are ready, we check again the baby. Show the woman it's fine. So we know exactly everything is fine, and the woman feel more comfortable. Regarding this new technique, I've shown you super high resolution and time of arrival images is a new tool which improve your confidence of diagnostics. It's like a multiparametric imaging, and I tell it it's like a one-stop shopping. Everything is summarized in one clip with a high resolution, so it helps you. We use this for difficult cases, and we can also use it now in different organs. There is no need to do it only on liver. You can also do it on kidney and pancreas or other vascular diseases. Again, I would like to welcome you in Munich, and I'm very open for any questions or remarks. Thanks for attention.
¿Alguien que le quiera hacer una pregunta al doctor? La pueden hacer en español, si la van a traducir al doctor. Para que no se preocupen por hacerla en inglés.
You can speak Spanish. I got a translator.
One of the biggest challenges we have in my institution is that mostly, like mainly the attendings are not accepting like the use of CUs nowadays. They prefer like doing the CTs, MRIs, and then they decide like to change the approach.
I think the translator doesn't hear it.
No. And she's speaking English.
Is it working?
She's speaking English.
Yeah, I thought
Okay.
I only get the stuff from the translator. So you speak English or Spanish?
It's not working.
No. Just repeat your question.
The issue we're having in my institution is that the attendings, they don't like using CUs. They prefer like doing first CTs, doing MRIs. So we're having like that challenge. We're offering them the CUs, and they're like, oh, I don't know, we don't like it that much because it's a little bit not objective. So how can we change the way they're thinking so we can like promote that type of studies? Because we know the advances that they can make, and we have showed them like some interesting cases which the ultrasound has shown superior even to the CT. But we're having like that issue with them. They don't like to change the way they're approaching this kind of.
I understand this completely. First of all, what I would recommend, do together workshops. Invite them to bring cake. Okay. So the best way will be to do workshops together. invite the doctors in a kleine conference and discuss cases. They see the advantage. It takes a while until then that they get the informed consent that they would like really to use contrast. But also think about how long does it take in your department to get an MRI?
It's about like 3 months.
3 months, okay. Think about your patient. Would you like to stay with a diagnosis of cancer for 3 months at home?
Not all.
Think about what happens in this 3 months with the cancer. Is it spreading somewhere else? And then you have to say to the patient, your house doctor recommend MRI. It takes 3 months, but we can do your diagnosis next day or just immediately. What do you prefer?
The next
I
day.
tell you, next day. And also, I think from the cost side, it's much cheaper, MRI. And if it's not clear, in ultrasound is much cheaper. And when it's not clear in the ultrasound, it also could happen in rare cases, we still could do additional MRI if it's really needed. But you could exclude all benign lesion where we don't need any additional MRI or CT. Yeah? So you save money, the patient feels better, and the diagnosis is similar.
Thanks.
Any other question?
Hi. Which are the findings in intraductal biliary lesions? For example, intraductal cholangiocarcinoma. They share the same characteristics in mass-forming cholangiocarcinoma with contrast ultrasound?
In contrast, for CCC, we have got this rim enhancement in the peripheral, and the washout is much earlier in comparison to HCC. But we have also mixed tumor. Sometimes we find a mix between HCC and CCC in a single tumor. But this case, I could not explain in contrast. Yeah.
Thanks.
Hi. Do you have any experience of the use in contrast in ovarian pathology?
Yeah, you can use contrast nearly everywhere. So you can use contrast for superficial organ like thyroid, carotid artery, peripheral vessels, deep vein thrombus, dialysis shunts, kidney, pancreas, spleen, myoma, trauma. You can use it for intervention to improve your biopsy, and you can also use it to follow up intervention directly. For example, if you who do microwave ablation? Okay, what is the cost about a single needle?
Being honest, I have like no idea. They just gave it to us.
About $1,500, single needle, if it's a cheap one. So if you do this, use this needle, and you make the follow-up next day by CT, and there's still viable tumor, you need a second one. If you do this examination with contrast directly after your intervention, where the needle is on the table, you still see there's viable tissue. So you can use your old needle still and place it a second time in. So you save a lot of money. And you could confirm whether your needle is on the proper place. That is really a big advantage. Any other questions?
¿Cuáles serían las complicaciones más? Gracias. ¿Cuáles son las complicaciones que más han visto en mujeres embarazadas con el contraste?
We have never have any complication in pregnancy. The risk of having complication that could happen is 1 in 10,000 cases. It's the same rate like MRI, but it's 10 times lower like CT. The good news, if you have got complications, they show up immediately. So you inject and the patient says, oh, I don't feel so good. No patient which we had complication have to stay overnight in the hospital. We just have to prepare. The fact is that we didn't know who's the 10,000th patient. You have to prepare in the room that something could happen, like CT or MRI. So you have got cortisone and phenyl in the room to inject it.
Cuando se tiene una cirrosis muy avanzada, ¿la función hepática muy alterada afecta el contraste?
No, it doesn't affect. The only stuff which affect is if the patient has got a thrombus in the portal vein. Because normally we have got two vessels in the liver which feeding the vessel. If we have got a complete thrombus in the portal vein, it makes it more difficult because we have only hepatic artery.
Okay. Y la forma de diferenciar, una de las lesiones más difíciles en pacientes con cirrosis avanzada es diferenciar si es un HCC versus un nódulo displásico.
Yeah, that's a good remark. I told you HCC have got a washout in the late phase. Dysplastic nodule have no washout. So if you have got a lesion with a maybe hyper-enhancing and no washout after 5 minutes, then it's a dysplastic nodule.
Thank you.
¿Cuál es la dosis máxima que podemos utilizar del medio de contraste?
So normally I've shown you use a half vial. Guess what was the maximum dose I have injected in person? How many vials? 2, 3, 4, 5. 5 vials in a single patient. What I have done, I have implanted an aortic stent graft only by contrast and ultrasound and X-ray. That's the reason why I use 5 vials, because it was not written in the literature. We was the first one. The second stent graft we could do with 1.5 vial. A good friend of mine from Bracco company told me when they do the registration for the contrast agent, they inject in a beagle, in a dog, 50 vials. I mean, it's not a problem because 99.7% is water. Yeah.
Okay, let me ask my question in Spanish. En relación con lo que usted acaba de comentar y en su experiencia, ¿cuál cree que usted que son los pasos o los tips and tricks en la detección y caracterización de las endoleaks post-TEVR?
I mean, we have a study with more than 1,000 patients for endoleaks. Summarize in the first way. If you only do grayscale and color Doppler, you miss 30% of the endoleaks. In this 1,000 patient study we have done, we could show that we was more sensitive in comparison to CT. We also look at the arrival time, and sometimes it took 90 seconds. After the aorta have got contrast uptake, it takes 90 seconds when the endoleak show up. At this time, the patient is from the table away already in CT. That's the reason why they didn't see it. And we have got a dynamic examination. We see the flow direction. So we can detect leaks better, but we can also treat leaks. So, for example, if we puncture the aorta directly and inject some glue, then you can see is it enough glue, yes or not. You can see whether the needle is at the correct position if you inject some ultrasound contrast agent over the needle in the aorta. And then if you inject glue, you inject over the vein contrast again, and you see it's gone or not gone. Then you have to inject another glue or not. And the problem is patients with endovascular repair need a follow-up until the end of their life. We have cases where we find for 5 years a leak. In the 6th year, the leak is gone. We have patients which we have got 5 years no leak. On the 6th year, there was a leak. You never know. You could avoid CT, but what is difficult in ultrasound is dislocation of stent graft and stent fracture. Therefore, our recommendation will be do a conventional X-plane of the abdomen, low dose, no unit contrast. You see pretty good the fractures of the stent or dislocation, and the rest could be done by contrast and ultrasound. But before we send the patient home, he received at least one CT as a gold standard to see what's going on in the future.
¿Cuáles son los falsos positivos y falsos negativos?
In endoleaks, the problem is
En las lesiones hepáticas en general, con el uso de contraste.
I mean, the false positives is if you have got a diagnosis, if the gold standard say it's maybe an FNH and you say it's an adenoma. And normally biopsy later proves it's an adenoma. Then you have got a false positive because the gold standard said it's an FNH, even if it was not an FNH. Yeah? That's the problem. Sometimes the gold standard is a problem. For example, for endoleaks, the gold standard is CT. What happens if CT doesn't see the leak? It doesn't exist. You have got a false positive. Even in the follow-up, you can say, there is it.
How long does it normally take to acquire a contrast ultrasound?
Normally, we make a decision direct at the patient. So in my department, we have 7 ultrasound equipment there, 7 systems. Every system have got contrast software on its side. And if other doctors find a lesion, they ask me, make it sense to inject contrast here. And then we do it immediately. We place a central line, we just let them sign the informed consent, and 5 minutes later, we got the diagnosis.
But I mean, how long does it take to acquire the entire exploration?
What do you mean?
How much time do you take to make a contrast ultrasound?
5 minutes. So if there's a central line, it doesn't take more than 5 minutes, because after 5 minutes there's no contrast anymore. So extra 5 minutes.
Over here, just one question.
Yeah.
What's your team experience using contrast ultrasound in like muscle lesions with perfusion? Like they've been using like the same protocol they use for myocardial to muscle lesions and their follow-ups?
You can use this, but normally you use higher frequency probes, so you use linear probes. This means you have to inject also more contrast. What we do, we don't do so much MSK, but we do, for example, free flaps to see whether the free flap has got a nice perfusion. Then we inject contrast and we see whether the perfusion of this tissue, of this flap is fine. And this is also very critical because, you know, a free flap is a very complex operation. And you, of course, would like to avoid that there is not enough blood supply in this free flap.
Thanks.
¿Se necesita de algún software especial para el ultrasonido para hacer este tipo de estudios?
Yeah. So first of all, I would recommend to see whether the software is already on your system. Yeah? Or ask your vendor whether you have bought it or not. Most of the system is like a Windows system. You have to upgrade PowerPoint on it. So also contrast software is also available at mid-range system. It must not be the high-end system. And if you have only a mid-range system, you could improve the sensitivity of the system if you inject a bit more contrast.
Thank you.
but you need software, otherwise it's not working.
Vamos a terminar la sesión para pasar al...
Hombre, qué sesión tan espectacular. Yo creo que de pie. Le damos una pausa de pie. Doc. De verdad, qué plática tan excepcional. De verdad, fue maravilloso. Hemos aprendido muchísimo con el doctor. Muchas gracias, doctor, por compartirnos su experiencia. Se ve que esto lo maneja súper bien, eso es lo que queremos nosotros. Todos los tips, esta plática fueron puros tips. Muchas gracias por ello. Nos ahorró miles de horas de estudio. Muchas gracias. Así es que le voy a pedir al doctor Alejandro que le haga la entrega de su reconocimiento y el agradecimiento también a Braco por permitir la educación médica continua. Un aplauso para Braco, por favor. Que hace que esto también sea posible. De verdad, muchísimas gracias. Gracias a ustedes porque ustedes hacen posible las sesiones. Así es que un aplauso también para ustedes. Y los invitamos al ambiguo. Gracias.